Usually, when you talk about medical diagnosis, there's this expectation of like mechanical precision.
Right.
Like you break your arm, the X-ray shows that jagged white line in the bone, and the doctor just points at the screen and says, there it is, broken.
Yeah, it's very binary.
Exactly. The binary, it's visible, and it's oddly comforting because, well, the path to fixing it is universally understood. You put a cast on it, keep it still, let the bone net.
Simple mechanics.
Right. But then you step into the world of chronic autoimmune skin conditions, and suddenly that X-ray machine is entirely useless.
Oh, completely useless. The diagnostic landscape turns incredibly murky.
Yeah, we're dealing with tissue that refuses to heal because it has fundamentally, gone to war with itself. It throws the traditional medical blueprint completely out the window.
It really does. And today, for our deep dive, we are looking directly into those muddy waters at a condition called vulvar lichen sclerosis.
Right, or LS.
Exactly, LS. But more importantly for you listening, we are exploring this massive paradigm shift in how science is approaching the cure.
Which is just, it's wild stuff. We're diving into how researchers are using these microscopic cell-free messengers called exosomes to literally reprogram chronically scarred, intimate tissue.
Reprogramming it specifically by altering the local ratio of collagen to elastin.
Yes. And to understand the sheer scale of what these cellular messengers are doing, we had to pull from a fairly diverse stack of sources for you today.
Yeah, we're looking at studies from medical journals like Gynecologia Polska, some clinic guidelines, and specific patient case reports that really track this regenerative shift in real time.
Right, to see what it looks like on the ground. But I guess if you want to understand how this exosome therapy rebuilds tissue, we first have to understand how the tissue is being destroyed in the first place.
We do. So lichen sclerosis is a chronic autoimmune inflammatory dermatosis.
And reading through the literature, the thing that really struck me is that this presents in a bimodal fashion.
Right, bimodal.
Meaning doctors typically see it spike in prepubertal children.
Which is heartbreaking.
It really is. And then they see another major wave of diagnoses in middle-aged or postmenopausal women. And I mean, the human toll here is just agonizing.
Yeah, the symptoms are incredibly severe. We are talking about intense pruritus.
Which is severe, unyielding itching.
Right, itching that just doesn't stop. Plus burning sensations, chronic pain, and eventually the literal fusion of the anogenital tissue.
That's just the physical architectural collapse happening beneath the surface of the skin. It's just profound.
It is. The Gynecologia Polska study really zeroes in on the extracellular matrix, or the ECM.
Okay, so let's unpack that for a second. The ECM.
Yeah, you can picture the ECM as the structural scaffolding that holds all your cells in place.
Okay.
It gives your tissue its specific shape, its strength, its resilience. But in a patient with lichen sclerosis, chronic immune activation basically launches an all-out assault on the scaffolding.
And the study specifically highlights the presence of ECM1 autoantibodies, right?
Yeah. Yes, exactly.
Meaning the immune system is actively producing antibodies that target and dismantle the very proteins binding the basement membrane of the skin together.
It's an internal demolition job.
Yeah. And this constant state of inflammation acts like a blaring, endless alarm bell for the local fibroblasts.
Yeah, the fibroblasts, which are the builder cells, they're the ones usually responsible for, smoothly maintaining that structural scaffolding.
But because they're forced to operate in this chaotic, highly inflamed environment, they're normal programming glitches.
They essentially go into a state of panic.
Right, panic mode. And instead of laying down a carefully organized matrix, these panicked fibroblasts start frantically pumping out abnormal, dense type of via collagen.
Just massive overproduction.
Yeah.
Which leads directly to sclerosis, which is a severe hardening of the tissue.
And alongside that, you get hyalinization.
Right.
Where the tissue takes on this unnatural, kind of glassy, rigid appearance under a microscope.
It's really striking to see. And concurrently, the immune response is destroying the skin's elastin fibers.
Which is the worst part, really. Elastin is that vital protein that allows any tissue in your body to stretch, bear weight, and snap back into its original shape.
Exactly.
So, okay, let's unpack this with an analogy. If we think of healthy, functional tissue, like a high-quality memory foam mattress.
I like this.
Right. Lichen sclerosis is essentially dissolving the bouncy springs, the elastin, and flooding the mattress cavity with rigid, unyielding concrete.
Which is the abnormal collagen.
Exactly. The tissue literally loses its compliance, its stretch, its bounce. It becomes rigid, easily torn, and incredibly fragile.
And that loss of compliance makes everyday life I mean, just sitting down, wearing certain clothes, let alone intimacy, physically traumatizing for the patient.
Right, and understanding that structural transformation from flexible memory foam to rigid concrete perfectly explains the biological limits of conventional medicine.
It really does. Because historically, if a patient presents with this condition, the frontline gold standard treatment is a tube of high-potency topical
Like
corticosteroids.
Clobetasol.
Right, clobetasol. And look, these steroids have a vital role in acute management.
Sure.
They aggressively suppress the localized immune response, which silences those blaring alarm bells.
Right, which temporarily halts the itching and slows the visible progression of those white plaques on the skin.
But, and here's where it gets really interesting, but also a bit confusing for patients. Shutting off the alarm doesn't magically repair the building?
Right, if a steroid cream successfully puts out the inflammatory fire, why doesn't the cellular forest just grow back on its own?
Because putting out the fire doesn't remove the burnt, dead trees from the forest. Even when a steroid cream successfully pauses the inflammation, that underlying fibrotic, scarred microenvironment is still sitting there.
The concrete is still in the mattress.
Exactly. The healthy elastin springs are still gone. The local stem cell niche, which normally handles tissue repair, remains deeply damaged.
And the local blood supply is completely choked off by that dense collagen wall.
Right, so that persistent fibrotic environment creates a relentless, self-perpetuating cycle of disease recurrence.
The patient applies the steroid, the localized itching fades, they taper off the medication,
And then the underlying scar tissue triggers the inflammation to return.
and the panicked fibroblasts wake up and lay down even more concrete.
Yeah, you are essentially just managing a slow, painful decline.
Man. So escaping that cycle requires a massive leap in medical strategy.
It does. And that brings us to the regenerative shift.
Right, because the goal of regenerative medicine isn't just to manage symptoms or temporarily suppress the immune system.
No, the objective is to restore tissue homeostasis, to fundamentally fix the immune regulation, reopen the blood flow, and give the local stem cell niche the exact instructions it needs to dissolve the scar tissue.
To literally remodel the matrix. And medical science is attempting to deliver those instructions using exosomes.
Exosomes. The term is everywhere in regenerative medicine right now.
Oh, it's the ultimate buzzword.
Ooh.
But the sources we reviewed are meticulous about defining what they are not,
Yes, they are not stem cells.
which is a huge distinction. Because for decades, stem cell therapy was viewed as the ultimate frontier of tissue repair.
Right, the idea being that if you inject living, viable stem cells into damaged tissue, they will grow into new, healthy cells.
But exosomes operate on an entirely different premise. They are extracellular vesicles.
Yeah, you can visualize them as tiny nanometer-sized lipid bubbles secreted by almost every cell in the human body.
So they aren't the cells themselves.
No, they are the highly sophisticated delivery packages the cells use to communicate with one another.
Right, they are the text messages of the cellular world.
I love that analogy.
So if traditional stem cell therapy is like bringing an entirely new construction crew to a damaged worksite, hoping they survive the transplant and figure out what to do, exosome therapy is just sending the hyper-specific blueprints and work orders via text message directly to the existing local crew.
That is exactly it. You bypass the logistical nightmares of transplanting living cells, which, carry immense challenges regarding cell survival rates and unpredictable differentiation.
Because you're just harnessing the chemical signals.
Right. Inside these tiny lipid vesicles is a dense, concentrated payload of bioactive substances.
We're talking about specific proteins, lipids, messenger RNA, microRNA, growth factors, and cytokines.
And what's truly wild is where these text messages can be sourced from.
Oh, it's crazy. The literature shows they are incredibly versatile.
Yeah, they can be autologous, meaning harvested directly from the patient's own body.
Like often isolated from platelet-rich plasma from a standard blood draw, or from adipose, which is fat tissue.
Exactly. Or, alternatively, they can be allogeneic, meaning they come from a donor.
Right, typically isolated from the mesenchymal stem cells of an umbilical cord.
But it gets even crazier. We also see the emergence of plant-derived extracellular vesicles.
Yes. One of the case reports in our stack actually utilizes exosomes derived from Rosa damascena.
The damask rose.
I mean, think about that. The fundamental biology of vesicular communication is so deeply conserved across species that a vesicle extracted from a rose can successfully deliver immunomodulatory and pro-regenerative signals to a human skin cell.
Prompting it to repair itself.
Cross-kingdom cellular communication. A plant instructing human tissue to heal. It sounds like pure science fiction.
It does, But the mechanics of how this works on the ground, inside the damaged vulvar tissue, is very, very concrete.
Right, because the core clinical objective here is rewriting that local collagen to elastin ratio.
Right. But to get those chemical blueprints deep into the rigid sclerotic tissue, clinicians can't just rub it on top. They often use synergistic technologies.
Yeah, they don't just apply a serum, they use fractional radiofrequency devices,
Yeah.
like Morpheus 8V or fractionated CO2 lasers.
And the term fractional there means the device is creating a grid of thousands of microscopic, highly controlled injuries in the scarred tissue, leaving healthy tissue intact in between.
Which sounds painful, but this mechanical action serves a vital dual purpose.
Exactly. First, the micro-injuries immediately shock the body's natural wound healing cascade into action.
It wakes it up.
Yes. And second, and more importantly for this therapy, the needles or lasers create physical vertical channels deep into the dermis.
So when the exosome solution is applied topically over this treated area, those tiny lipid bubbles travel down the channels.
Bypassing the hardened surface layer entirely, going directly to the depth where the panicked fibroblasts are located.
And once they breach that barrier and find those fibroblasts, it's like a hostile takeover.
Basically, the microRNA and growth factors inside the exosome essentially hack the cell.
Right, they overwrite the inflammatory software the fibroblasts have been running on.
The payload binds to the messenger RNA inside the fibroblast and actively halts the overproduction of that dense fibrotic type I collagen.
The chemical text message literally commands the cell to stop pouring the concrete.
Stop the concrete. But halting the damage is only half the equation.
Right.
The exosomes concurrently stimulate the synthesis of healthy, carefully organized collagen fibers.
And crucially, they upregulate elastin production.
Yes. They provide the precise epigenetic instructions the fibroblast needs to start rebuilding the bouncy memory foam springs.
Which restores the mechanical compliance of the tissue.
Exactly.
But restoring the scaffolding is incredible, but the tissue also needs a lifeline, right? Which brings us to the blood supply.
Right, because in lichen sclerosis, that dense wall of fibrotic tissue physically crushes the microvasculature.
The capillaries are choked off, meaning the tissue is constantly starving for oxygen and nutrients.
And the exosome payload addresses this directly by delivering potent pro-angiogenic factors.
Angiogenic meaning creating new blood vessels.
Right. Most notably VEGF, or vascular endothelial growth factor.
Okay, VEGF.
Yeah, VEGF is a signaling protein that specifically binds to the endothelial cells lining the inside of blood vessels.
So when the exosome delivers VEGF into this oxygen-starved environment, it triggers those endothelial cells to multiply and sprout new vascular tubes.
You are quite literally watching the body rapidly build a new capillary network, infiltrating the damaged area to restore profound local blood flow.
And you combine that fresh blood supply with the immunomodulatory cytokines in the exosome payload.
Which communicate with the local T cells and macrophages, commanding them to stand down and shift from a pro-inflammatory attack mode to an anti-inflammatory healing mode.
And boom, you are addressing the autoimmune root of the disease alongside the structural damage.
It's a two-pronged approach.
Now, taking this out of the theoretical realm, the clinical reality of this mechanism is beautifully illustrated in one of the specific case reports we reviewed.
Yes, the 57-year-old woman.
Right. It details the treatment of a 57-year-old woman grappling with a 3-year history of refractory vulvar lichen sclerosis.
And refractory is such a cold clinical term, but for the patient,
it's a nightmare. It means 3 years of trying every standard steroid cream and protocol available, only to watch them fail as the disease continues to ravage her body.
Yeah. Her clinical presentation upon examination was severe. She was suffering from unmanageable pruritus, constant burning, and dyspareunia.
Which is severe localized pain during sexual intercourse.
Right. And structurally, the physician observed depigmented atrophic plaques, a drastic reduction in skin elasticity, and the partial fusion of the labia minora.
The architectural collapse was advanced.
Very advanced. But because traditional care had failed her, the medical team pivoted to a regenerative protocol using autologous nanofat combined with exosomes.
Okay, so they performed a minor liposuction procedure to harvest a small volume of her own adipose tissue.
Right, because fat is incredibly rich in regenerative potential. But you can't just inject raw fat into the dermis.
Well,
They mechanically process this adipose tissue, breaking down the large fat cells to isolate what is known as the stromal vascular fraction.
okay, wait, what exactly is the stromal vascular fraction?
It's essentially a potent cellular soup. Once you strip away the lipid-storing adipocytes, the fat cells, You are left with a dense concentration of endothelial cells, immune cells, and mesenchymal stem cells.
Which are the adult stem cells that natively reside in your fat tissue.
Exactly. And this fraction is extraordinarily rich in naturally occurring exosomes.
So when this processed nanofat, alongside additional isolated exosomes, was injected directly into her affected vulvar tissue, the local cellular environment was just flooded with regenerative blueprints.
Flooded. And the clinical outcomes recorded in the report are staggering.
Yeah, she didn't just experience relief from the severe itching and pain, though that alone would be life-changing after 3 years.
Right, but the physical structure of her tissue transformed.
The report explicitly documents that her tissue's elasticity and mechanical compliance were restored.
The rigid concrete was dissolved and the flexible scaffolding was rebuilt.
It's amazing. We are observing the transition from merely managing a slow decay to actively facilitating biological tissue restoration.
The physical architecture of the skin reverts toward a functional, healthy state because the local cellular software has been updated.
Right. But, and this raises an important question for you, the listener,
Oh.
with so many aesthetic clinics popping up and offering these treatments,
Yes.
how on earth do you separate the cutting-edge science from the snake oil? Because while rewriting cellular software sounds like a miraculous, futuristic cure, bringing this science out of controlled lab environments and into commercial clinics introduces a host of very real logistical dangers.
It really does. If these tiny vesicles are so incredibly effective, why isn't every dermatologist immediately throwing away their steroid creams?
Right.
The reality is that exosome therapy is still largely considered investigational.
Yeah, the FDA has issued multiple warnings about unapproved exosome products being marketed directly to consumers.
Exactly. And the guidelines from Perfect Doctors Clinic provided in our sources meticulously outline the clinical realities and the fragility of this treatment.
They highlight 5 specific risks that demonstrate why this is still heavily categorized as an emerging science.
Let's go through them. The first and most immediate is the risk of infection.
Right. Whether a clinic is harvesting and centrifuging the patient's own blood or fat, or utilizing a donor vial of umbilical exosomes, absolute flawless sterility is mandatory.
Mandatory. If a clinic cuts corners on their sterile protocols during the preparation or the microneedling phase,
They aren't just introducing exosomes into those deep dermal channels.
no, they're pushing bacterial or fungal contaminants directly into a compromised vascular bed.
Which leads to severe localized infections, fevers, swelling, which entirely defeats the purpose of trying to heal the tissue.
Completely defeats it. And even in a perfectly sterile environment, we hit risk number 2. Patients must navigate localized inflammation.
Right, because you're introducing a massive concentrated dose of bioactive particles coupled with the physical trauma of laser channels or microneedling.
That will trigger the immune system's initial defense mechanisms. The body registers the sudden influx of material and the micro-injuries, and it responds with localized swelling and inflammation.
It's a necessary phase of the healing cascade, sure, but it requires careful patient management.
Absolutely. Then you also have to consider the biological origin of the payload, which introduces the third risk, rare allergic reactions.
Okay, so if a patient is receiving an autologous treatment using their own processed fat, the risk is minimal, right?
Right, because it's their own tissue. But if a clinic is applying allogeneic umbilical cord exosomes or plant-derived rose exosomes, they are introducing foreign proteins into an already hyperreactive autoimmune environment.
And individual sensitivities to specific proteins within that donor payload can trigger allergic responses, ranging from localized rashes to, in extreme cases, respiratory distress.
Exactly. Which brings us to the fourth risk, which speaks directly to the physics of the exosome itself.
The temperature control.
Yes. We established that these are nanometer-sized lipid bubbles. That structure makes them incredibly delicate.
Yeah.
Their structural integrity dictated the entire efficacy of the therapy. If a clinic fails to maintain the rigorous deep freeze temperatures required for storage,
Or if the provider mishandles the thawing and preparation process.
the lipid bilayer of the exosome simply ruptures.
Tops.
Yep, and the internal payload of microRNA and growth factors degrades instantly upon exposure.
So the patient endures the cost, the injections, the downtime, only to receive a placebo of inactive, degraded cellular debris.
All because the clinic's freezer fluctuated by a few degrees.
Wow.
Yeah. Which brings us to the fifth and perhaps most complex reality of regenerative medicine, the unknown horizon of long-term effects.
Right. The mechanisms we've discussed, sending powerful concentrated signals to fibroblasts to proliferate and build new tissue, or signaling endothelial cells to sprout new blood vessels. These are potent biological levers.
Very potent. And if you are continuously instructing cells to grow and remodel, you run the theoretical risk of the tissue overreacting.
The sources explicitly mention the potential for unwanted cellular proliferation.
Or paradoxically triggering new forms of tissue fibrosis from overtreatment.
Because we simply do not possess decades of longitudinal data to definitively state how these local cellular environments will behave 10, 20, or 30 years after receiving repeated exosome bombardments.
We just don't know yet. Navigating this landscape requires extreme diligence from the patient.
Yeah, the proliferation of aesthetic med spas heavily marketing these therapies demands a hypercritical approach.
Patients must demand transparency regarding the exact origin of the exosomes, the clinic storage capabilities, their sterile protocols, and the specific regulatory compliance of the products being utilized.
You are looking for a board-certified professional, like a gynecologist or a dermatologist, who possesses a deep foundational understanding of the underlying pathology of lichen sclerosus.
Not just someone who purchased a centrifuge and a radiofrequency device.
Exactly. So, to pull this all together, our journey through the literature today illustrates a profound evolution in medical thought.
It really does. We started with the rigid, devastating reality of lichen sclerosis, examining how the autoimmune destruction of elastin and the overproduction of abnormal collagen physically robs tissue of its compliance.
And we acknowledge the vital yet fundamentally limited role of traditional steroid interventions in managing the inflammation without actually repairing the scarred landscape.
Right, and from there, we unpacked the mechanics of vesicular communication.
We explored how delivering this specific microRNA and growth factor payload of an exosome deep into the dermis can intercept the panicked fibroblasts
Halt the production of dense concrete.
and stimulate the rebuilding of the flexible memory foam scaffolding, alongside massive improvements in local blood flow via VEGF.
Moving from the suppression of symptoms to the active, targeted restoration of tissue architecture represents a monumental leap in how we approach chronic disease.
It does. And for you listening,